Hey, today we're going to talk about Module 13, which is mobility. We're also going to learn about herniated nucleus pulpus, Parkinson's disease, and spinal cord injury. Here you can see your learning outcomes. Just take a few seconds to look over those and we'll move on. Okay, we'll get started with herniated disc. Herniated discs are characterized by pain and paresthesia that follow a radicular pattern or nerve pattern. It may be that there is one or more herniated discs in one area or more than one area. When the disc between two vertebrae herniates, it moves out of the normal anatomical position. In most cases, the annulus fibrosus, the tough outer ring of the disc, tears. When this happens, it allows escape of the nucleus pulpus, the soft inner portion of the disc. This displaced tissue passes on one or more new nerve roots, causing pain. The cause of herniated disc may be unknown, or it may be due to injury. In some cases, there is a known injury. It could be from a fall, lifting, or possibly a motor vehicle accident. Other times, there's no known injury that caused disc to be herniated. Signs and symptoms of herniated disc include pain, muscle spasms, numbness or tingling of extremities, weakness, and atrophy. Cervical disc herniations cause pain and muscle spasms in the neck. The patient may have decreased range of motion secondary to pain. Hand and arm pain is unilateral and follows the distribution of the spinal nerve root. Numbness and tingling to the extremity may be reported. Asymmetrical weakness and atrophy to affected muscles may occur. If weakness involves the entire extremity, it is unlikely due to a herniated disc. The severity of the pain or paresthesia doesn't necessarily correlate with the severity of nerve compression, but weakness and atrophy are indicators of significant nerve compression. You have your thoracic herniations. They are not very common. This part of the spine has less mobility. If one occurs, they report back pain. Lumbar herniations are typically characterized by low back pain, pain radiating down one leg, paresthesia, and weakness. They will have a limp on the affected side and may have problems walking on their toes or the heels of the affected side. Muscle spasms are present and may cause limited range of motion. Deep tendon or DT reflexes may be decreased or absent. Make sure you check out page 1141, the What's Up mnemonic. It can be used to assess symptoms of a herniated disc at any level. Herniated discs are diagnosed by MRI or myelogram. If you check out pages 1381 and 1382, Appendix A, you can find the descriptions of both an MRI and a myelogram. Therapeutic interventions contain rest, physical therapy, traction, muscle relaxants, NSAIDs and analgesics, epidural anesthetic, steroids, or surgery. 1 to 2 of bed rest followed by a careful and gradual increase in activity. Physical therapy can be very helpful. Progressive exercise will help strengthen the muscles, particularly in the lumbar area where muscles need to stabilize the spine. Ultrasound, electric stimulation, heat, and ice with deep massage can help with pain and muscle spasms. It also helps to increase range of motion. They also teach proper body mechanics in physical therapy. In traction, you have cervical traction. It is a non-invasive technique sometimes used by physical therapy. They use a halter-like device that is placed around the head with ropes and weights that pull to slightly separate the vertebra and allow for the disc to return to its place or to give temporary relief while in traction. If this causes the pain to worsen, it is discontinued immediately. Traction is not effective for the lumbar because of the large amount of weight that is needed to pull, and this may cause injury. For your medications, you have muscle relaxants. They're often used short-term for muscle spasms. They also help increase range of motion and activity. Muscle spasms serve as a protective mechanism to limit activity, lessening the chance of further injury to the disc, although chronic spasm can cause tearing and scarring. Teach that drowsiness is a common side effect of muscle relaxants and some analgesics. Diazepam or Valium, Soma, Robaxin, and Flexeril are all muscle relaxants. Make sure that you know that Valium has a strong potential for addiction. NSAIDs are used in reducing the inflammation at the nerve root. Several NSAIDs are available, and it may take trying several ones to find one that will work the best. When looking at epidural anesthetics or steroid injections, it may be used if the other, more conservative treatment doesn't work. A mixture of a long-acting steroid, anesthetic, and pain reliever are injected into the epidural space. This can be repeated every 3 to 4 months. Opioid use is okay in acute back pain, but it's only for short term. If the pain becomes chronic, opioid use can cause constipation, tolerance, and dependence. All of these would need to be discussed between the patient and the physician. Pain clinic referrals are always a good option. Topical lidocaine patches, NSAID patch, or neuropathic pain agents like Lyrica, Neurontin, and Elavil can be helpful for long term. Complementary and alternative therapies such as a transcutaneous electric nerve stimulator or a TENS unit, because it's non-invasive and it can be very helpful. Physical therapy or a pain specialist will assist the client to learn how to use this TENS unit at home. Surgery is less common than in the past, but if other treatment doesn't work, a laminectomy is performed. A laminectomy removes one of the lamina, the flat pieces of bone on either side of the vertebra. This helps to relieve pressure or to gain access for removal of the herniated disc. A discectomy is the entire removal of the disc. Discectomy to the cervical area is usually done from the front of the neck. The disc is replaced by bone or other material. Bone may be used from the patient's iliac crest or a cadaver bone. Lumbar discs are done from the back. Pulling some of the muscle from the bone causes this to be more painful post-op. Percutaneous discectomy uses a large needle to remove disc material. Laser and laparoscopy may be used. Artificial disc may be used for select cases. Surgery complications. Hemorrhage is possible, but it's not common. Airway is a concern if the surgery was done anteriorly and hemorrhage occurs. Monitor for bleeding and respiratory distress. If you have nerve root damage, if the nerve root is severed during surgery, there will be a loss of motor and sensory function in the area that the nerve innervates. If the nerve root is damaged or excessive scarring occurs, the patient may have pain, weakness, or paresthesia. Reherniation can occur 1 week to several years out. If it occurs within a few weeks to months, another surgery may have to be done. This won't occur in the cervical area since the entire disc has been removed. Herniation of adjacent disc. Fusion of the cervical spine results in loss of movement at that segment. This can place more stress on the other areas increase the risk of other herniation. For preoperative care, you want to do routine teaching. You want to do pre-op teaching. Make sure you teach the patient the log rolling technique and explain to them this will help avoid twisting at the spine, and this will prevent injury from occurring. You can see pre-op teaching on page 209 and 210. Some things will be contraindicated for this type of surgery. Your nursing diagnosis include acute pain, risk for impaired urinary elimination, and risk for impaired physical mobility. You want to monitor color, warmth, and pulses in the extremities. Monitor for changes in circulation, movement, and sensation. Report any changes to the physician. Monitor for pain. Monitor surgical site and for any drains. Also monitor for cerebral spinal fluid drainage or any abnormal bleeding. Don't forget the donor site. If the bone was taken, this is another surgical site to monitor. Intake and output should be monitored, and make sure you assess the patient's ability to void. See Nursing Care Plan on page 1143. Next, we're going to talk about spinal stenosis. It's a condition where the spinal canal is compressing the spinal cork. Arthritis is the major cause of spinal stenosis. Now we're going to be talking about spinal cord injuries. You see your pathophysiology. You have damage to nerve fibers. They interface with communication between the brain and the body. Damage may be caused by bruising, tearing, cutting, edema, or bleeding into the cord, caused by external forces or bone fragments. Spinal cord injuries can be caused by MVAs, falls, sports injuries, or an assault. Causes are similar as those with traumatic brain injury. It is not common for these to occur together. Most common is your motor vehicle accidents. Females more often experience this through falls. Males during acts of violence or sports. Assault can be caused by knife injury or bullet wounds. Also diving into shallow water. A complete spinal cord injury means there is no motor sensory function below the level of the injury. Incomplete lesions, some function remain, some painful and not useful. Cervical and lumbar areas are more often affected than the thoracic and sacral areas. Cervical injuries depend on the level at which the cord is damaged. See page 1145. Can affect all four extremities, causing paralysis, paresthesias, impaired respiratory function, and loss of bowel and bladder control. Paralysis in all four extremities is called quadriplegia. Weakness in all four is called quadriparesis. If the injury is C3 or above, it is usually fatal since the muscles for breathing are paralyzed. C4 or C5 usually need ventilator support and long-term assistance with activities of daily living. Thoracic and lumbar injuries can cause paraplegia or paralysis. They may also have altered bowel and bladder control. Immediately after the injury, the cord below the injury stops functioning completely. This causes a disruption in the sympathetic nervous system, resulting in vasodilation, hypotension, and bradycardia. This is called neurogenic or spinal shock. Hypothermia is also a result of vasodilation. They cannot control body temperature, all reflexes are lost, and retention of urine and feces occur. Spinal shock can last 1 to many weeks. Complications of spinal cord injury have infections such as pneumonia related to impaired respiratory effort, decreased cough, mechanical ventilation, and immobility. Also, Foley catheter placement can lead to UTIs. In DVTs, it's caused by a form of immobility. SCDs, TEDs, heparin, or Lovenox are all preventative measures to prevent blood clots. Orthostatic hypotension. There is no longer muscular function in the legs to promote venous return. This can cause orthostatic hypotension. There is a pooling of blood in the legs. You want to gradually raise the head of the bed and use reclining wheelchairs. This can help lessen the symptoms of orthostatic hypotension. In skin breakdown, you want to cushion the bony prominences. Remember, they may not have sensation and won't feel the need to move and can't move themselves properly. These patients must avoid pressure injuries. With your renal complications, UTI is going to be a concern for patients with spinal cord injuries. Teach the caregiver and the patient how to monitor for color, odor, and clarity of urine, and notify the physician of any suspicions of UTI. With depression and substance abuse, there's a higher than average incidence in these clients. Autonomic dysreflexia. This is life-threatening complication and occurs in patients with injuries above T6. The injury impairs the normal equilibrium between the sympathetic and parasympathetic nervous systems. Most common cause is bladder distension. Also, bowel impaction can cause this. UTI, ingrown toenails, pressure ulcers, pain, and labor in pregnant women can also cause this. Stimulation of the sympathetic nervous system results in cool, pale skin, goose flesh, and vasoconstriction below the area of injury. Blood pressure can rise to 300 systolic. When the parasympathetic nervous system is responding, it causes vasodilation, flushing, and diaphoresis above the lesion, and also bradycardia as low as 30. Understand that it cannot respond past the area of injury to counteract the central nervous system. Patients usually report a pounding headache and nasal congestion secondary to dilated blood vessels. Here you can see different spinal cord injuries and where they occur. This image is located on page 1145, figure 4811, and you can see it much better in the book. Spinal cord injuries can be diagnosed by X-ray, CT scan, and MRI. In emergency management, carefully monitor vital signs and airway. Also keep the patient immobilized. Intubation with mechanical ventilation may be necessary. IV normal saline for fluid replacement is necessary, along with the need of medication if the patient is hypotensive. But remember, too much fluid could cause overload and not correct the hypotension, so the patient may need to only be on medication. IV steroids to decrease inflammation may be started by EMS. In respiratory injuries above C4 and C5 have some degree of respiratory impairment. Tracheostomy may be necessary. A phrenic nerve stimulator may help with breathing by causing the diaphragm to contract. These patients use mechanical ventilation at night to give the phrenic nerve a rest. Continue to monitor the respiratory status in those who are breathing when they arrive. Swelling can later impair the ability to breathe. If they are intubated prophylactically, reassure them that it's probably temporary until the swelling goes down. Gastrointestinal absence of bowel sounds is common. Oral and enteral feedings will not be started until bowel function resumes. GI system, an indwelling catheter is placed to prevent bladder distension and protect skin. Immobilization, C-spine will be immobilized with skeletal traction. Could be Crutchfield or Gardner-Wells tongs. You can see that on page 1147, top of the page. Some may also have a halo, and you'll see that on the next slide. This keeps the head and the neck immobile while fusion and healing takes place. Here's a type of surgical management. This is an example of the halo brace. The goal is to stabilize bony elements of the spine and relieve pressure on the spinal cord. It may or may not improve function. Rods may be used to stabilize the lumbar and thoracic injuries. These patients may also wear a corset, a rigid brace, or a body cast. Here's another example of skeletal traction. You can see this image on page 1147. It's figure 4812, and it shows you an example of a Crutchfield tongs or Gardner-Wells tongs. Here we're looking at nursing diagnosis for spinal cord injuries. You have your impaired gas exchange, ineffective airway clearance, risk for autonomic dysreflexia, reflex urine incontinence, constipation, and impaired physical mobility, ongoing evaluation of all body systems is imperative. Frequent neuro and respiratory assessments are essential. You must keep in mind discharge and family support systems for these patients. More nursing diagnoses include self-care deficit, risk for impaired skin integrity, risk for ineffective role performance, risk for sexual dysfunction, and anxiety. You want to see the care plan on 1148 through 1153 and the interventions. Make sure you look over those. And also aging with spinal cords injury, that's on page 1147 in the box. And there's also a summary on page 1154. Parkinson's disease may be a genetic component, especially in younger patients. Environmental toxins may play a role. The use of certain drugs like phenothiazines may have a role in it. An outbreak of encephalitis was linked to Parkinson's in the 1920s. Onset of symptoms is subtle and gradual. Loss of dopamine-producing cells occur before symptoms. Symptoms can be mistaken for aging or fatigue. In hindsight, patients and their significant others can see symptoms they have missed. Bradykinesia is slow movement. Akinesia is the inability to move. Changes in posture and tremors may occur. The brain can no longer direct the muscles to perform in the usual manner. Safety in ambulation is severely affected, which also affects ADLs, leisure activities, and the patient's self-esteem. There is difficulty in initiating movement. This affects starting walking, rising from a sitting position, or to begin dressing. Voluntary movement will be slow, and the patient may experience a freezing of gait. Extensor muscles are often affected more than flexor muscles. This results in stoop posture, flexion of the hips, knees, and the neck shifts forward towards the center of gravity. The gait is shuffling, and once they get going and increase in speed, they may have trouble stopping. Turns may be difficult. They are at high risk for falls. They also have difficulty catching themselves should they fall. In most patients, the tremor then moves to the contralateral side or the opposite side. One side of the body may be more affected. Pill rolling is typical, more noticeable when the extremity is at rest. Drinking and reading is virtually impossible at times due to tremors. Signs and symptoms are worse with fatigue. Secondary signs and symptoms include general weakness, muscle fatigue, and difficulty with fine motor skills like buttoning shirts, tying shoes, and handwriting. Soft, monotone voice with mask-like facial expression can make the client look like there is no emotion. One thing that we need to be aware of is the decrease in eye blinking response. Corneal abrasions are a concern. Caregivers need to be aware. If you look on page 1161, you'll see table 4811, symptoms of Parkinson's disease versus essential tremors. The autonomic nervous system dysfunction can cause diaphoresis, constipation, orthostatic hypotension, drooling, dysphagia, seborrheic dermatitis, that's red itchy rash on your scalp that has flaky scales, is a common skin disease that looks similar to psoriasis, eczema, or allergic reaction. Slowness, balance problems, and frequent urination cause urinary incontinence. Late in the disease, mental function may become slow and may develop dementia. Also, side effects of anti-Parkinson's drugs make this worse. Death is usually a complication of immobility. See page 1161. There's also a Parkinson's video there if you can pull it up on your computer. Diagnosis of Parkinson's is usually done through history, physical examination, and an MRI. The MRI will be done to rule out any other causes. Therapeutic interventions, there's no cure. Treatment is aided at controlling symptoms and maximizing function. Drugs are listed on table 4012 on page 1162. On and off phenomenon. Patient may experience a decreased response to levodopa or off period, especially when the dose is wearing off. As the disease progresses, the off periods may be less predictable. They may then have a delayed response to the next dose, leaving them in an off mode for a period of time. A drug holiday may be helpful when they are maxed on their medicines, may be able to reduce the dose after the holiday, but they must be closely monitored for safety. Surgically, you have a pallidotomy for rigidity, tremors, and bradykinesia. It's performed only on one side of the brain when they're awake. You also have deep brain stimulation. A tiny electrode is placed into the brain tissue with a generator implant in the chest attached to the electrode. Electrical stimulation may help the symptoms. Complications of Parkinson includes falls and injuries, constipation, joint immobility. They're unable to perform ADLs, swallowing impairment, and depression. Your nursing diagnosis include impaired physical mobility, self-care deficit, risk for injury, and diagnosis for dementia. Review questions. Which assessment finding does the nurse expect in the patient with Parkinson's disease? Select all that apply. Your answers are 2, 3, and 5. Which assessment should take priority in a patient with a cervical spine injury who suddenly exhibits a spike in blood pressure? Your answer is number 1, perform a bladder scan. That's all for Module 13. If you have any questions from any of the information that's been provided, just make sure you send me an email or a text message.